Okay, thank you, Simon. Well, good evening, everybody. So I'm delighted to introduce the second session in the NPA's 2021 conference. And our speaker this evening is Lisa Simpson, who is the Deputy Director leading the Community Pharmacy Policy team and also has wider responsibilities around the Pharmacy Integration Fund at NHSE and I. Together with her colleague Jill Loader, she's responsible for all NHSE and I work on community pharmacy, working closely with the Chief Pharmaceutical Officer and his team who provide clinical input. So the NHS long-term plan in early 2019 set out the key objective of securing triple integration of primary and specialist care, physical and mental health services, and health and social care. And community pharmacy certainly has a role in supporting all three of these objectives. And the 5-year contractual framework published 2 years ago in July 2019 set out how community pharmacy will play its role with particular focus on urgent care, prevention and medicines optimisation. And more specifically, services such as community pharmacy consultation service and discharge medication service were introduced with that contract. And alongside this sits the PCN service specification. And many of these PCN services could benefit from contributions from community pharmacy, including structured medication reviews, supporting early cancer diagnosis, enhanced care in care homes, cardiovascular prevention diagnosis, and tackling health inequalities. So Lisa this evening is going to talk about the topic of integration and new services in community pharmacy. So we'll have some time for questions towards the end of the session. So please do use the chat function throughout to put your questions in, and then we'll collect those together and ask Lisa to comment on them at the end of the session. So now I'm delighted to hand over to Lisa for this evening's talk. Thank you, Lisa.
Thank you, Gareth. Good evening, everybody. Hello. As Gareth says, I've been asked to talk to you specifically about our ambitions here at NHSE and I around the integration of services. I hope that the takeaway message you're going to get from this presentation is one of opportunity. Undoubtedly, an opportunity with challenges associated, but opportunity nonetheless. Next slide, please. So, where to begin our journey? We've obviously been talking about integration in the NHS for a very long time, so there are many starting points, depending on how far back you want to go. I've taken my starting point this evening as the 2019 5-year deal, and this slide has a couple of statements taken from it. That document described a shared vision, and I think these statements encapsulate that quite well in just sort of 3 short statements. The first one really does recognise that we were asking people and organisations to work differently in ways they've not done in the past. And I think we all acknowledge that is difficult, that we set you a challenge, that it's a journey, it will take time. The second statement, I think, describes our ambition around integration and about your ability to be seen by the rest of the NHS as part of that provider landscape locally, as part of that extended multidisciplinary team. And the last is very much about our desire to see the sector delivering clinical services. Next slide, please. So what have we been doing to turn those statements in that document into something concrete? How are we measuring up so far? So in the first one, where we said we wanted you to work in ways you hadn't done in the past and that we wanted the system to collaborate more, I think that's probably best exemplified by the community pharmacist consultation service, where we're really trying to establish your position as the optimal place to go for minor illness. We wanted to have you seen as a key provider in a patient pathway. And I think that is again exemplified by the Discharge medicine service. It's a really good example about how you can be an integral part of a patient pathway and add massive value. And the third one, where we were talking about you being a key partner in a primary care network and delivering clinical services, that's where we look to your potential role in structured medication reviews and in some of those other service specs. And I think hypertension case finding is a really good example. Next slide, please. So starting with the community pharmacist consultation service, we really think this has been an opportunity to establish your relevance to the rest of the NHS as a partner, as well as to patients. The referrals from 111 have been a success. I think we know in some ways, though, that that was probably the simplest place to start, the referrals from 111. It gave us all a foundation to build from and confidence and a good story to tell. But it is that, it is only a foundation, it is not the end of the journey. We launched the referrals from general practice during the pandemic, and we recognise that that has been a harder journey. It's been slower to start, but it's not slow everywhere. So we are confident that it can take off. We don't think there's a systematic reason that it can't be successful. It's absolutely now a clear priority for all of us. And when I say us, I mean all of us. It's not just NHSE and I. What can we all do? From NHSE and I's perspective, we're actively looking now at what more we can do to promote and accelerate general practice engagement and their uptake of the service. And that includes us emphasising it in the NHS planning guidance in March, which is one of our really big set piece documents. And we put the most important things in that document, and we talked about the role of this service in that document. It certainly got a nod. And I think we feel that the context is good now as we're coming out of the pandemic, as we're approaching yet another winter, with COVID booster jabs and flu jabs being important, with access to general practice being an issue of concern. We think that that strength of argument really does make it a solid priority in everybody's eyes. I think from a sector perspective, what can you do? We've all got something to do here. And I guess I'd challenge you to say, what does working differently look like? If this service is really about working differently, what does that look for you? You know, your clinical skills are not, you are all very able to offer an excellent clinical service here. So what is it that you need to think about differently? And so, for example, a GP is part of your customer base as well as your patients. How is it that you're approaching that from a different viewpoint? Next slide, please. So just to in front of you from the data. So firstly, I draw out that it's having a positive impact on patients, with nearly 500,000 patients already having benefited from quality access to minor illness support. Looking at the numbers here, I hazard the guess that the sector could do more. A run rate of 3 patients per month doesn't feel like an endpoint to me. Very interested to hear your views on that and how far you think you could go. The most recent data we've got on GP uptake shows that the majority of pharmacies have undertaken their positive engagement with general practice, and that's absolutely great. You've really stepped up and started that, and you're now waiting on general practice to operationalise the services locally, and that needs to be our focus as a team. Just looking at the early data that we've got, I think if we scaled up these activity numbers and translated that up to a national level, it would probably more than double the monthly run rate. But again, can we all expect more? Can you do more? do you want to do more? Lastly, on this slide, just a bit of a shameless plug for the clinical skills training. Many people have taken part in that, but more places are available. So just putting that on your radar. Where next for CPCS? It's no secret that we are interested. We'd like to see referrals from me. And no doubt you'll see more from us in pilots that we hope to start operationalising soon. Next slide, please. I don't see the next slide yet. Ah, fantastic, thank you. So Discharge Medicine Service. So this is the service that it just ticks all the boxes, doesn't it, from an integration perspective. It establishes your contributions in that context of being an integrated part of the NHS pathway. You're linking in with acute trusts locally, you're supporting the patient in the community, you're getting the information across to general practice for that ongoing care. And we absolutely know from the evidence base that you are making care safer. Many of you have been participating in this service already through the NHSE CAM programme, and it's really valued. Next slide, please. So how's this one doing? So this is very early data. This isn't yet in the public domain, but early data is showing us that about a fifth of pharmacies have had referrals to date. I don't have the relevant number of hospitals to put alongside that yet. This really is very, very early data, so we don't yet have the right readout of the number of participating trusts. But you can see that over 13,000 patients have benefited in what are 3 short months. Extrapolating on this referral data can give a really good indication of the impact that this will have had on the acute sector in terms of avoided admissions and bed days avoided, which is significant. This is purely an extrapolation at this point, and the central team is working hard behind the scenes on how we properly evidence the value and how we can show the patient outcomes that have been achieved from your clinical inputs. And just worth noting again on discharge that the NHS planning guidance did press home the importance of timely and appropriate discharge. So this is really important to the centre, and it's fantastic that you can support that. Next, please. So my last vignette is around medication reviews, attention case finding, and this is that space where you can contribute to the work being led in primary care networks. So it is the primary care network that is funded to undertake structured medication reviews, but that's not to say community pharmacy can't support that. There is obviously a need to have the relevant clinical training in place. But on the assumption that that is in place, then a community pharmacist could work as part of a PCN team, either in a sessional way or other way, as if they've got a portfolio type career and they have more than one employer. Or alternatively, the community pharmacy itself could be used by the PCN to undertake some or all seminars. So it might be that GPs particularly are interested in their patients on non-steroidals or on opioids. It might be if they've got an area of high health inequalities, they're interested in getting some support for their diabetes patients who maybe aren't turning up in general practice very regularly. So there's plenty of opportunities there. I think one of the things we're really interested in is how we link these different medicines focused services together. So for example, if you receive a referral for the discharge medicine service, can you spot something in there? Is it worth referring a patient for a structured medication review? Does something trigger your interest? And how is it you then locally make sure that that flow of information works and that supports a patient? Similarly, if a patient has a structured medication review, if they have a number of changes to their regime, could you get a referral to say this patient would really benefit from a new medicine service on their adherence? How is it that you can make sure that link of the fact that you can offer that adherence support around the new medicine service, how is that communicated so that the clinician doing the structured medication reviews make sure the patient knows that you can help them adjust? So we're really interested in that, how that stuff links together and how to get the best for patients. And finally, just on that support for the primary care network space, you'll be aware that we're piloting blood pressure checks at the moment from the Pharmacy Integration Fund. And this is really interesting for us from this perspective of seeing your role as being able to onward refer into general practice if you find individuals who you think need treatment. And that's a really interesting space for us to explore, and the pilots are giving us very positive feedback, and it's one we're interested in. Next slide, please. So, implementation. So if the message from me so far is that there's lots of opportunity, that we're on a collective journey to implement new clinical services, that we know there's more to do, and to get the best impact, I guess we all need to play our part. So that action should be involving all of us. This slide sets out some of the efforts that are going on. So, for example, we have implementation groups for the services we commission via the CPCF that meet regularly. They have nominated regional leads. We're tailoring reporting arrangements for them so that they can quickly spot their progress and identify where they need to make more efforts. Your local relationships are absolutely key. Clinician to clinician, manager to manager, building trust, co-producing plans. We can certainly do a lot from the centre, but building that personal relationship is something only you can bring to the table. On IT, we absolutely know this is a much needed enabler. The complexity of the IT systems makes it difficult to do a one model fits all type approach. And we recognise that this does benefit from some local decision making and ownership. We need to work through this together. We recognise that this is one of the challenges, and some of our focus has been on trying to set those national standards, those APIs, trying to get everybody on the same page. We've got lots of communications activity in train and guidance and toolkits and support networks. And we're really keen to take on a quality improvement approach to our implementation. We really know these are new services, and we're keen to hear about how they can be improved. What is that continuous improvement journey? Have we got all of our documentation right? Have we got the services nailed? Are our service specs ambiguous and unhelpful or unclear in particular areas? And we're beginning to initiate those sorts of evaluation discussions. We'd love to hear from you about that. And I think it's probably just worth saying and acknowledging that some of the activity we're doing here might be a bit invisible to you. And I guess that's because we're working with those wider audiences of GPs or hospital pharmacists, particularly where the services require them to act. You know, our efforts might be in building a bit of toolkit to help an acute trust make decisions, and that maybe is not that visible to the community pharmacy sector, and it can seem like we're not doing anything. Keen to hear from you what you think we can do and where you think our efforts would be valuably placed. Next slide, please. So we've begun our journey towards integration. We've got some example services which show what we're trying to achieve here. So we're in the here and now, but we're always asking about the what next. So we will obviously continue to pilot new ideas through the Pharmacy Integration Fund. We're keen to accelerate getting some pilots off the ground once the pressure of the pandemic response allows. And I would like to just say a personal thank you to NPA members for supporting our Integration Fund pilots. You are innovative and agile, and you are trailblazers, and you really do help us in that key design work for us to think through what we want to commission nationally, and we recognise the support that you offer there. Where else on the integration journey? Well, we've mentioned the primary care network services. We've picked out a couple here. There are 7 of them. Those are a clear indication of what we're hoping to achieve in primary care. So very worth familiarising yourself with those and thinking about what can community pharmacy do in those spaces. The obvious next big thing on our radar, on all of our agendas, is the creation of the integrated care system through the health bill. And these new commissioners will have a focus on population health and have a focus on health inequalities. There'll be opportunities for more local tailoring. And again, an opportunity here for community pharmacy to really exploit its unique selling point. The ease of access, the breadth of the network, the bucking the inverse care law, your presence in those community settings, and your ability to connect with people is fabulous. So I think integrated care system commissioners could be an exciting chapter. As part of that, you might hear the integrated care provider mentioned, and that's where the government is thinking about bringing more collaboration locally between different providers in an area and trying to reduce those barriers of competition and make it simpler for organisations to work together. So there's things to explore in that space which were not previously open to us all. And then a last shameless plug, I guess, for your How Can We Help plan, which I've had shared with me today. I would say there's some very good ideas in that document. There's an awful lot that we've got in common of how we see the future of the sector going. So it was good to see that document. Thank you for sharing it. And my next slide is, please, thank you for listening, and any questions?
Okay, well, thank you very much, Lisa. Well, thank you for mentioning How We Can Help, which is a document that we've launched just today, setting out our views on how the independent community pharmacy, or the community pharmacy sector really, can meet the NHS's current challenges, including dealing with the rest of the pandemic and getting clearing the backlog, but also making community pharmacy the first port of call, and the really strengthening our role in prevention. And also thank you for acknowledging the agility of independent community pharmacy, which we strongly believe that's one of the great strengths of independent community pharmacy, local relationships, and that ability to respond really quickly to needs and opportunities. So if you've got any questions for Lisa, please put them in the chat. I was hoping actually first to pick up on your comments about GP CPCS. It's obviously top of everyone's mind at the moment. I'm just wondering, do you have any sort of specific examples, as I suppose, of how to make this work locally? Because I think, there are all 1 or 2 areas in the country that have a fair bit ahead of everybody else. Do you have any views on how they've been able to achieve that in ways that perhaps other people could follow?
help, certainly, where the LPC is able to be an active partner in that work. And I think the examples where we've seen it working best is where there's boots on the ground, for want of a better expression, but somebody's going in and doing a bit of hand holding, a bit of awareness raising, and a bit of myth busting. And I think that a small effort on that scale can reap big rewards. So that's definitely been a key to success. There is still the relationships, I think, as well. And I think we see, not that those relationships have got to be perfect and pre-exist, but where those relationships are already strong, it does accelerate the pace at which this goes. So time that can be spent on building those relationships, I think, is time that was valuable.
And could we also pick up some of the comments you made about the PCN service specifications? And I think there was a lot of attention given to these when they were first announced 2 years ago, and obviously everyone's attention has been elsewhere for a lot of the time since then. I'm just wondering if you could perhaps tell us a little bit more about the timetable really for those services, and again perhaps a bit of advice on how can we best engage and sell ourselves into PCNs when trying to highlight where community pharmacy can help.
So the timetable is a brilliant question that I'm unable to answer, because of course that will all be part of that conversation that happens with general practice. So there's ambitions described to get those up and running across the period of that 5-year general deal with general practice. But the detail of quite when they come in and at what pace is not something I'm able to give a great deal of clarity on, I'm afraid. How can you contribute? I mean, you would have better ideas than me, so I don't want to say that I'm the font of all knowledge in this space. But we've obviously identified hypertension and blood pressure checks as something that can definitely be part of CVD prevention and diagnosis. We at the centre have identified the sort of smoking cessation transfer of care pilot that we've got, which could be part of the early cancer diagnosis prevention. Tackling neighbourhood inequalities, well, we've got healthy living pharmacies now everywhere, but what's the next step for a healthy living pharmacy? What's your role in that health check, and how can you kind of link into that social prescribing type ethos, which brings us into that personalised care space. So what can pharmacy do in the self-management space, in the over-prescribing space, in taking control of medicines, and in that shared decision making? You know, that you've got excellent clinical skills, you have the time to talk to people about the medication and what it feels like and how to adhere to it. So how can that be connected with that shared decision making type activity? How can you bring that out? Enhanced health in care homes. I think the medicines optimisation in care homes programme speaks to that brilliantly. But more to do in that medicines optimisation space. You know, we're hoping to launch a pilot around contraception and pharmacy's role in monitoring women on regular contraception and supporting repeat prescriptions and supply. And we, you know, there are opportunities with every stone you lift, I think. The only constrained by our imagination.
Yeah, and that's a service that we've been supportive of for a long time, and seeing as a really good service opportunity for community pharmacy. We're just actually slightly over time, but if I can just ask one last question, and it's I think in part this reflects some of the comments we get from some of our members that a number of the services require others really to be on board and to drive it, and the CPCS, is a good example. And like to see some more services where actually they can fully drive it. And actually, one example would be the ability to refer patients into other parts of the NHS, whether that is a formal route into the general practice, a formal route into A&E, or in some cases a formal route into another specialist that the community pharmacist identifies that the patient needs to see. Do you see that as being something in the not too distant future within the integration work stream?
I think that's a really exciting proposition, Gareth, and I think that it would be fabulous to work with some of your members on designing pilots that might allow us to explore some of that in quite a defined way. I think that's a really interesting space.
Okay, well, thank you, Lisa. That time passed very, very quickly. Thank you very much for joining us this evening and giving us that really helpful update on where we are with integration in community pharmacy services. This evening, actually, we have another NPA conference session. So at 7:30, Simon Dukes and NPA board member Jay Badenhorst will be discussing securing the right representation for community pharmacy. So that's coming up in just under half an hour's time. And our conference continues through until Thursday with several sessions every day. And don't forget that all of these sessions are recorded and can be watched on catch up via the NPA website. So thanks again, Lisa, and thank you to everybody for joining us this evening, and good night.